Good morning. My name is Jennifer Mitchell, and I work for UCSF in San Francisco in the departments of Neurology and Psychiatry. And I've been invited to give you a brief overview of post-traumatic stress disorder, termed PTSD by most, and on the possibility of using MDMA to treat PTSD.
And so I thought I'd start with a bit of a definition and explanation. PTSD is what occurs in response to experiencing or witnessing a traumatic event. And in order to meet the diagnostic criteria as defined by the DSM, PTSD must follow exposure to actual or threatened death, serious injury, or sexual violence. And it must involve each of the following four criteria: intrusive thoughts, avoidance, altered mood and cognition, and altered arousal and reactivity. And to give you a better idea of the types of symptoms that meet those four criteria to qualify for this diagnosis of PTSD, I've broken it down a little bit further here. So PTSD consists of recurrent, involuntary, and intrusive distressing memories of a trauma, as well as efforts to avoid external reminders that would arouse those distressing memories of the trauma. And in addition, PTSD involves a persistent negative emotional state. And this can take on a number of different forms: fear, anger, guilt, depression, or reckless or self-destructive behavior. And it should be said that these symptoms are a standard response to a traumatic event and typical. We'd all experience some of these symptoms following a trauma. So none of them on their own is considered abnormal or dysfunctional. But to meet criteria for PTSD, these symptoms must last for more than a month, and they must cause significant distress or problems with daily functioning. And it should also be said that not all PTSD is created equal, and that there is a subtype of PTSD, which is termed dissociative PTSD, that is considered to be particularly treatment resistant, and in which patients, in addition to meeting the criteria that I just discussed on the previous slide, also experience at least one of the following: depersonalization, which is the persistent or recurrent experience of being detached from or outside of one's own body; and derealization, which again is persistent or recurrent experience of lack of reality in your surroundings. So experiencing the world as dreamlike or as chronically distorted. And I think it's important to keep these more intractable cases in mind when we consider developing novel therapeutics for PTSD, because we want to reach everyone that's in need of help. And in terms of frequency, about 7 or 8 out of every 100 people, so that's 78% of the global population, will have PTSD at some point in their lives. It's a very, very large number of people. And within the United States, about 8 million adults have PTSD during any given year. So that gives you an idea of how very common this disorder actually is. And then in terms of the population of people that suffer from PTSD, we know that there are sex differences. Specifically, about 10% of women will develop PTSD at some time in their lives, as compared to about 4% of men. And we don't really know why there is this sex difference, but it may be due to experiential differences, since women are more likely to experience sexual assault or child sexual abuse, and men are more likely to experience accidents and combat-related trauma. And since by definition, childhood sexual abuse occurs earlier in development, it is often considered intractable or treatment resistant. And so again, important for us to keep in mind when considering novel therapeutics. And to break this down a little bit further for you so that you know how common these childhood abuses actually are, within the United States, from the last national survey, we know that approximately 40% of children, so this is aged 1 to 17, experienced a physical assault in the last year. And that almost 14% of those also experienced maltreatment by a caregiver. 2% experienced sexual abuse in the last year. And if you just carve out the adolescent girls from that sample, the numbers rise rather precipitously. So almost 11% of girls aged 14 to 17 experienced a sexual abuse this last year. So again, these are important metrics to keep in mind when considering novel therapeutics. The global annual costs of PTSD are in excess of billions and billions of dollars. But if you try to break it down to per patient costs, as a couple of groups have recently done, you find that within Western Europe, the 5-year healthcare costs, and this is just healthcare costs specifically, are roughly 43,000 euros per individual. And that's more than 3 times what it takes to care for an individual that does not have PTSD. So it's a very big difference in healthcare costs. And then within the United States, we've collected data from a military population that was deployed during the last 2 conflicts. So these are termed OEF and OIF. And we followed 261 plus thousand troops through 2008 and came up with a 2-year social cost for just treatment of depression and PTSD. And that was in excess of $923 million. So again, very large number. And I should mention that PTSD doesn't often resolve without treatment. So these costs continue to accumulate. The 2-year costs are just the tip of the iceberg. There are a number of co-occurring or comorbid conditions that are associated with PTSD. Approximately 80% of PTSD patients have at least one comorbidity. And when a patient experiences comorbid disorders, it typically increases their treatment resistance. So again, this is an important metric to track as we develop new therapeutics. And the most common comorbidity that occurs with PTSD is anxiety disorder. So approximately 60% of those that have PTSD also have an anxiety disorder. In addition, about 1/3 of the individuals with PTSD experience a depressive disorder, and almost half report alcohol and substance use disorders, or both alcohol and substance use disorders. And it's also important to keep in mind that approximately 1/4 of the individuals that suffer from PTSD have also experienced a traumatic brain injury. The only 2 medications that are approved for the treatment of PTSD by the FDA are the SSRIs sertraline and paroxetine, so better known as Zoloft and Paxil. And in addition, there are a number of sleeping aids that are typically prescribed for PTSD. The major one is Prasasin. Prasasin is an alpha-1 blocker, so it affects norepinephrine. And for a long time, it was thought to perhaps help with nightmares, which is one of the largest complaints in those suffering from PTSD. Unfortunately, a couple of years ago, it was shown to be no better than placebo, so we're back to the drawing board when it comes to sleeping aids. There's also talk therapy, so cognitive processing therapy and prolonged exposure therapy are the gold standard therapies for treatment of PTSD. And then more recently, there's EMDR, which is eye movement desensitization and reprocessing therapy. But in general, this isn't much. And so this paucity of treatments means that there's great room for improvement. So with that, what is MDMA? MDMA is shorthand for 3,4-methylenedioxymethamphetamine, which is a substituted amphetamine. It was first synthesized by Merck in 1912, so this is not a new compound. And it acts by potentiating serotonin release. And it does this via a series of different mechanisms in your brain. And then on a secondary level, it also increases levels of 2 important neuromodulators, oxytocin and vasopressin. It can be dosed orally, which is incredibly convenient. And the onset of action is relatively fast, between 30 and 60 minutes. And a single dose of MDMA lasts upwards of about 6 hours. And so why look at MDMA as a potential treatment for PTSD? First, we have a lot of data from animal models. So from animal models, we know that, or from mice in particular, we know that MDMA facilitates the extinction of fear memories. And it does this in a part of the brain that we know is involved in the storage of fear memories, and it does this through a serotonergic mechanism. And that data dovetails rather nicely with data from rats, which has shown that systemically administered MDMA can impair the reconsolidation of a fear memory. So when taken together, this suggests that perhaps MDMA induces a modification of a fear memory during a period of reconsolidation, and that allows a participant to process it and let it go. In addition to all those data from rodent models, we also have this rather anecdotal data from octopi, which show that a very low dose of systemically administered MDMA can potentiate social behaviors over solitary behaviors. And octopi are particularly solitary creatures. So this suggests that this is a particularly well-conserved mechanism of serotonergic function. And from that, if we make the jump into clinical data, we know that there have been a series of recent phase 2 studies that have used MDMA in a variety of subject populations with PTSD, and that these have consistently found that MDMA shows promise on both safety and efficacy measures. And in terms of how MDMA might be working, I like this quote from Dr. Midhofer from several years ago. He said that MDMA may catalyze the therapeutic process by allowing patients to stay emotionally engaged while revisiting traumatic experiences without becoming overwhelmed by anxiety. So perhaps MDMA opens a window of opportunity that permits us to address a trauma with a patient in a manner that doesn't initiate their withdrawal or their detachment. And so in short, these data led to our participation in the recent phase 3 trial in which MDMA was administered to 90 subjects, 3 times each, in conjunction with manualized therapy. And that manualized therapy was sandwiched before and after each of the 3 MDMA treatment sessions. And then the final outcome measures were assessed 2 months after that 3rd MDMA dose. And what we found in brief, if you look at the orange wheel on the left, is that 67% of the participants that received MDMA plus therapy no longer met criteria for PTSD at the end of the trial, compared to 32% of the participants in the placebo plus therapy group. So that is a very significant difference. And if you break those data down and take a more detailed look by treatment session, here we have PTSD symptom improvement over time. The red line indicates the MDMA group and the blue line indicates the placebo group. Again, both groups received therapy. And we see that for PTSD symptoms specifically, the groups basically start at the same amount of PTSD symptomology, but over time, the lines bifurcate further and further after each administration of MDMA or placebo. And then at the end of the trial, they are very significantly different, with the MDMA group experiencing better treatment outcomes. Similarly, if we track disability symptoms over time, we also find that these 2 lines deviate more and more following each drug administration. So both groups do experience some recovery in their disability symptoms, but there is a robust effect in the MDMA plus therapy group compared to the placebo plus therapy group. So again, the red line compared to the blue line. And then lastly, although symptoms of depression were not considered an inclusion criteria for participation in this study, as I previously mentioned, depression and PTSD are often comorbid. And so for that reason, we were also tracking depressive symptoms over the course of the study. And what we found is that the average baseline depression inventory score in this population was quite high. So this is actually considered a severe score on this depression inventory at baseline for both groups. And that over time, again, we looked at depression at study termination, depressive symptomology, and found that while both groups did improve, the MDMA plus therapy group was significantly more attenuated in terms of depressive symptomology than the placebo plus therapy group. So what was very interesting to me about these data in particular is that this is true for all subjects that received MDMA, including those with comorbidities. And again, as I mentioned earlier, that's very important because those with comorbidities are often considered to be more treatment resistant. So in summary, I'm hoping that I've demonstrated that PTSD is an all too common disorder for which new therapeutics are desperately needed, and is safe and effective in this subject population that had severe PTSD. and that there's a significant decrease in symptoms of PTSD as well as symptoms of depression following MDMA-assisted therapy. And lastly, and importantly, that there is no significant difference in the effects of MDMA in those that had comorbid conditions such as childhood trauma or with dissociative subtype.
So again, my name is Jennifer Mitchell. I work for UCSF in San Francisco, and I thank you for your time and attention.